I'm Dr. Tim Wilson. I'm Chair of Urology at the Providence St. John's Cancer Institute. And tonight we're here to talk a little bit about how great our robotics program is at Providence St. John's. And tonight I'm here with Dr. Anton Bilchik, who is Professor of Surgery at the Cancer Institute, also Director of the Gastrointestinal Research Program, and Chair of the Division of General Surgery at Providence St. John's Health Center. And tonight we're going to talk to Dr. Bilchik about how robotic surgery has changed his career and how he uses it to treat cancer patients every day. And so let me start by introducing Dr. Bilchik. Welcome. Nice to see you.
Nice to see you too, Dr. Wilson.
So Anton, first tell us a little bit about yourself, where you're from, what your educational background is like, and a little bit about your training.
Yeah, so I'm South African. I went to medical school at the University of Witwatersrand in Johannesburg. After finishing medical school, I did my PhD thesis in gastrointestinal physiology at Yale University. I've always had an interest in gastrointestinal disease, and one of the premier training programs was UCLA. So that brought me to Los Angeles, where I did my general surgery training, and then more time in the lab in the field of gastrointestinal physiology and cancer.
So you have a PhD also. Is that where you got your PhD as well?
Yes, in gastrointestinal physiology.
I see.
In evaluating the role of cholecystokinin in the pancreas.
Tell us a little bit about surgical oncology and the different diseases that you treat and manage.
Well, at UCLA, I got to meet Dr. Donald Morton, who was Chief of Surgical Oncology at UCLA, and very much of an inspirational person. And he was just starting a surgical oncology fellowship program at St. John's Health Center in Santa Monica, and he invited me to do my surgical oncology fellowship training with him, and then really encouraged me to start a gastrointestinal cancer research program back in 1998.
And has that been really the focus of your career?
It has, and I think that what makes Santa Monica special and what makes St. John special is we're really a tertiary referral cancer center or hospital in a community environment. And in 1991, Dr. Morton was the single highest funded clinical cancer investigator in the whole country at a community hospital.
Yeah.
And so he really encouraged us to write research grants and really practice bench to bedside medicine with a view to new discoveries.
You know, that I think some of the people watching might find it interesting that you can practice academic level or university level, oncology, surgical practice and research in a community hospital. Can you really compete with the big boys in that regard?
We really can, in the sense that when I wrote my R01 grant, which really is only 8% of them are funded in the whole country. No one looked at our hospital and said, "Oh, because you're not a university, you have a lower chance of getting the grant funded." They looked at the quality of the work, and the history of this cancer institute is such that it got awarded and really provided me the platform to compete nationally and internationally in the field of cancer research.
Sure. Tell me a little bit about the kind of patients that you see and the different diseases that you see, different kinds of cancers in the clinic, and the consults that you do.
As a gastrointestinal surgical oncologist, I get to see patients with cancers of the gastrointestinal tract, which include the stomach, the pancreas, the liver, the colon, and the rectum. Occasionally we see patients with esophageal cancers, but those are mostly managed now by thoracic surgeons.
I know that sometimes you and I do cases together, so you work with other specialties as well. How do you find the collaboration here at this hospital in this program, as far as your surgical expertise is concerned?
Well, we could not be able to function and practice as tertiary care providers without working as a team. And I think that what our patients really like and what provides excellent care is our ability to collaborate. The fact that we are in different specialties, yet we work out of the same clinic. We take on some of the most complex cancer operations that require multiple disciplines. Right. And we're able to do that. And these kinds of surgeries are, again, mostly done in university settings, but we've been able to create an environment that we can do these major operations collaboratively with excellent results.
Do you feel like you have the latest techniques and medications and surgical, let's say, equipment available to you, and for all a variety of surgical cancers?
We do now, because with you coming and Dr. Linehan coming from City of Hope, it brought a very large interest in robotic and minimally invasive surgery. Robotics has largely been in the hands of the urologists for many years. Sure. Before the gastrointestinal surgeons and the thoracic surgeons really developed an interest in robotic procedures. And so when your team came over, that immediately created even more interest in minimally invasive surgery for other disciplines. Right. And which led to cutting edge equipment, 3 robots, teams of nurses and assistants who are really very skilled at working with the robots. So again, it just fits with this theme of creating programs, bringing well-known surgeons from different places to be able to work collaboratively to take on some of the most complex cancer problems.
So I'm going to come back to robotics, but tell me a little bit about other disciplines that are available to you in terms of like imaging, radiology, pathology, medical oncology, things that you might use to help round out the care of your patient.
So in many ways, I think that we're quite spoilt at St. John's in the sense that we get our imaging done within hours. We can get our reports and results within a day. Our pathology team is excellent. We involve them in our conferences and our multidisciplinary tumor boards, and again, we get results in a very rapidly. And we also have just excellent nurses and support staff. We're, as I often tell our fellows, we're only as good as the people around us are. Right. And having that level of skill really makes a huge difference.
Hey, so and you brought up the fellows. So tell us a little bit about what a fellow is, what they do, how they participate in the patient care.
Surgical oncology until recently was a fellowship which required general surgeons who were either accredited or board certified to spend 2 years training, but they wouldn't necessarily be boarded in a specialty. That all changed about 5 years ago, when the American College of Surgeons recognized surgical oncology as a specific specialty with its own board, similar to urology or vascular surgery. Right. And the St. John's Cancer Institute, formerly the John Wayne Cancer Institute, was the 3rd program in the whole country to become ACGME approved as a fellowship training program. So we take 4 fellows a year, and after 2 years they get to take their board exams in complex general surgical oncology and have a separate specialty that is now recognized.
Now, some patients might think, well, I don't want to go to a place where someone, less than Dr. Bilchik's taking care of me. A fellow, someone that's still being trained. Tell us, why is that? Tell us about the fellows, how they interact with patients, and how that benefits patients.
Yeah, that's a very interesting question, because I think many fellows come to our program because they look at our program as an apprentice model, as a way to follow us, watch us, learn from us, help us, but there's one-on-one contact. Yeah. Our patients love spending time with fellows. Right. Many of them establish friendships with them. The fellows are deeply invested in their care.
Yeah.
And there are times that patients will ask to see our fellows rather than us.
Sure.
So it really is a model that I've never had one patient question the interest of a fellow or think that the fellow is managing the care and not and not me.
You mentioned a little bit about the robotics and other programs that are involved in robotics, but what do you think that how do you use robotic surgery? What kind of cases do you use it for, and how is it most beneficial to your practice and your surgical cases?
So we use robotics mainly for colorectal surgery and hepatobiliary surgery. So specifically difficult rectal cancer patients with colon cancer, stomach cancer, pancreas, and liver. I think that what the robot allows is a level of dexterity that you cannot get or duplicate with laparoscopy, the ability to visualize in 3-dimension, that again, it's just not possible with the same acuity as laparoscopy. And constantly the equipment appears to be changing, appears to be getting better. The fact that one can attach a robot to an operating room table that can move up and down is a major advancement. But I think really the ability to visualize nerves and blood vessels that you just can't see as clearly as doing a case open or laparoscopic, and the ability to get into difficult places like deep in the pelvis.
Right.
We've learned a lot from watching your team operate when we're dealing with difficult cancers deep in the pelvis. There's some cancers and some rectal problems that would be practically impossible to do open that the robot allows you to access.
Yeah. Some patients will ask me, Doctor, isn't it true that you want to be able to touch the tissue with your hands? Do you find that there's a disadvantage in that regard with robotic surgery?
It's rare that it's a disadvantage. In fact, I think it's the opposite, because what we're learning now is that one of the major advantages in robotic gastrointestinal surgeries is to be able to do bowel connections without touching anything. What that means is after a bowel connection is done with the assistance of the robot and without touching the bowel, there's less chance of the bowel spasming up. So patients that have what we call intracorporeal anastomoses are literally eating dinner the same night, and many of them go home one or 2 days after surgery. So for me, what I've seen is that is a game changer.
Sure. Did you ever think that was possible 10, 15 years ago?
Not a chance.
Right.
Not a chance at all. And there really is no better way to be able to connect two pieces of bowel without touching anything else than with the assistance of the robot. Again, because of the dexterity, the instrumentation, the robotic staplers. So again, I think that really is a game changer, and I'm hearing that more and more among my colleagues in terms of just quicker recovery, quicker return to bowel function, and getting back to normal life as quickly as possible.
Welcome, Jen.
Thank you.
Dr. Linehan is an associate professor in urologic oncology at the Cancer Institute, and she's the section head of translational research for urologic oncology. So Jen, just a couple of general questions I have about you and your background. So tell us a little bit about where you're from, where you studied and your education, where you went to college, some things like that, please.
So I was born in Cleveland, Ohio.
Cleveland, Ohio. Are you a Browns fan?
I am a total Browns fan and will always be a Browns fan, for sure. And my other favorite sports team is actually the Cubs and the Browns.
Yeah?
So I'm really good with the underdog teams. So I was in Ohio till I was about 11. We moved to Chicago. That was the love of the Cubs back then. And then basically moved on to Arizona. And I was in Arizona and Tucson for about 14 years before I came to LA.
And I should know this, but I don't remember exactly. What was your bachelor's degree in at Arizona?
Oh, in Arizona, I had a biochemistry.
Yeah?
And then I had a minor in business and Spanish. which then I did medical school, followed by residency. So I was there for about 14 years. And then after residency, I came out to do a robotics specialized fellowship in urologic oncology at City of Hope. And I was there for 2 years after that fellowship. And I stayed on at City of Hope doing robotics for about 3.5 years, 4 years, and then came over to St. John's in Santa Monica.
And why did you want to become a doctor? Why did you want to go into medicine?
So going into medicine, that actually happened for me when I was in high school. I was 17 and we actually did a cat lab. And I thought that was the coolest thing I had ever done. And that was the moment I decided I was definitely become a doctor and was on the doctor train all the way after that.
Sure.
So in college I did mostly studied science or biochemistry, got my thesis in biochemistry, and then those were all the requirements for medicine by then. So.
Right. What was your favorite part about medical school?
My favorite part about medical school is that in your 3rd and 4th year, you get all of this introduction to all the different specialties. So you get a chance to sort of learn about everything all at once in that small period of time. But medical school is also when I decided to become a urologist.
Yeah. So there aren't very many women urologists. In fact, I think, I might have this right, that of all specialties in medicine, urology has the lowest percentage of women. Is that accurate?
I don't know if it's all the specialties, but I think we're about 25% now.
Yeah.
Which it was about 10% when I was in medical school going into residency, so it's definitely changed.
Right. And so why urology? What attracts you about the specialty?
Well, really, it was robotics that attracted me to urology because urology was one of the first specialties to really use robotics and integrate it into their practice. And I will never forget the day I was in I think it was my 2nd year of med school, and we had a professor and he came and he showed us a procedure called a partial nephrectomy, and he was removing a tumor out of the kidney. And he had this robot with him called ESOP. And he used the robot to move the camera in and out. And he even had the robot give him compliments during the procedure.
Right.
So that was really interesting. So I just kind of fell in love with robotics. And then I had learned simultaneously that they were coming out with like 3 different platforms of robotics. And I remember the next morning at 6 a.m., I sat at his office, waited for him to come, gave him my CV, and I was like, I want to do what you do. I want to do robotics.
I see. So now, some people might have the impression that robotic surgery means that it's a programmable procedure. You press a button and the robot does the surgery. Is that how it works?
That is not how it works, but patients ask me that all the time.
Yeah.
They will always be like, well, you're controlling the robot, right? So that is not how that works. I control the robot the whole time. The robot is basically an instrument that goes inside the body that uses very tiny instruments and tiny hands so that we can manipulate the organs in a very gentle fashion without having to make large incisions. And then I use those small instruments inside your body to do the surgery from a separate console. So
yeah, and how do you think, so when you were in training though, you did open surgery as well. You did, some surgeries that required big incisions, big cuts, but you did some robotics, and then I know you did, as you said, you did the fellowship at City of Hope for 2 years. So what is it about robotics that has changed, surgery, that it's allowed this transition to from open or big cut surgery to small incision, minimally invasive surgery, and how has it helped surgery, do you think?
I think specifically for urologists, robotics changed prostatectomies forever. I mean, that was a very hard surgery to do open because of where the prostate was, which was very far underneath the pubic bone. So when you were doing those surgeries, many times, you sometimes couldn't even see where you were throwing your sutures. And so when robotics came out, it changed the way we did prostatectomies and really enabled us to see exactly where we were going, to see where the nerves to the prostate was, to see how we were putting the urethra back together again. And so I think it was instrumental in advancing the field for patients with prostate cancer.
Now, you use the robot for what cancers, and how do you use it primarily?
So I primarily use the robot for kidney cancers and also bladder cancers. So for the kidney cancers, it also really helped the urologist because you would have to make large incisions through the ribs, over the side of the body, and sometimes even taking a rib to get to the kidney.
Right.
And this incision was very difficult and very painful for patients to heal from. Those large incisions often cause the patients extra pain and longer hospital stays. We've also found that using the Da Vinci robot, because we're able to get in smaller spaces and dissect out vessels, also is associated with less bleeding. So the robot has really been instrumental in helping us do kidney reconstruction, prostate reconstruction, bladder reconstruction, because we can be into places that normally we weren't able to get to open.
Right.
And so it allowed us to get to the kidney, to get to the tumor, to cut out the tumor, and then reconstruct the kidney in a very concise fashion that really controlled bleeding that was much different from open surgery. And in most cases, patients go home the same day or one day later, which really changed because with these incisions, sometimes patients were in the hospital for 5 to 7 days.
Right. Other than kidney cancer, which you have a special interest in and special expertise, you also have an interest in bladder cancer, and not just an interest. I mean, you're an expert with bladder cancer diagnosis and management. And tell us a little bit about when patients have advanced bladder cancer and how they're managed, and then I'll ask you some questions about the surgery that might be done.
So patients that have advanced bladder cancer or bladder cancer that is invading into the muscular wall of the bladder are patients that are candidates for a cystectomy. And traditionally in the past, these procedures were done open through a larger incision. The bladder was completely removed, and the surgeon made a new bladder using intestine. And so it is a very complicated surgery and a very specialized surgery. So one of the things we do here at our institution is we tend to focus on what we call a 2-surgeon team. So we have 2 robotic urologists, oncologists that are working together. One is removing the bladder and the other one is doing the reconstruction. So they're very focused on both of their portions of the surgery, and all their efforts are going into that. And when patients have their bladder removed, there's a lot of changes that will happen with their body by using the bowel to recreate a bladder. So one of the things that the surgeon who's removing the bladder might focus on robotically is, again, because the vision is so much better, there's better nerve preservation, and there can be a better lymph node dissection, and the incisions are much smaller, and there's much less blood loss oftentimes with robotic surgeon because you're looking at such a level of precision. And then our next urologic team comes in, and they're going to do the reconstruction. And again, that has to do with taking the bowel and then hooking the bowel back up to the urethra so that the patient can void normally.
Now, not all. So there's a couple of different kinds of urinary reconstruction, or ways of, once if the bladder is removed, there's different ways of getting, allowing the urine to come out safely. So to tell us about some of the, just briefly about some of the options and how and how, what's life like after having your bladder out and having a urinary reconstruction?
So for most patients, there's 3 options. One option is that the urine can drain to their abdomen into a little bag. We can recreate, the second option is we can create a bladder that's much like their own, made out of bowel, that drains through the urethra.
So in that situation, patients would actually urinate naturally?
Normally, yes, in a normal fashion. And while, I tell patients it doesn't feel like the normal sensation for urination, they often will have a sense of fullness in their abdomen, and that's when they know they actually have to go and void. With patients, who have more trouble with walking, hand dexterity, or have any kind of kidney dysfunction, we tend to prefer them have a bag where they have a piece of bowel that comes out to the abdomen that drains the urine, and they put a little bag over it to collect it, and that's called a conduit.
And those patients actually have a stoma, a little, right?
Yeah, a stoma.
I see. Yeah, gotcha.
And that's the piece of bowel that comes out. And then the other patients, we call that a neobladder, and they patients void like normally. And then we have sort of a last type of reconstruction that we can do where the patient actually catheterizes a very small stoma on their abdomen, and they drain the urine themselves through the catheter. So, and again, all of these are very complex reconstructions that we do with bladder surgery, and we're now doing all those robotically to help avoid big incisions and improve recovery times.
Let me ask you a little bit about some of the newer things with molecular profiling and genetic testing in medicine, and how it might be impacting your practice now, and how you think it's going to impact medicine in the future.
So there are a lot of different companies that have offered genetic profiling of not just the patient's natural DNA, we call that their germline DNA, but what we call somatic mutations that are within their tissue. So these companies basically take the tissue and do genetic analysis that is trying to find mutations that you can target with different types of either chemotherapy drugs or immunotherapy. And this is really changing practice because, number one, it's helping us to categorize and locate some of these mutations. And two, it enables us to, instead of just giving the patients any type of chemotherapy or even surgical treatment, it's specialized to the specific cancer they have, to the specific mutation they have within their cancer.
Right.
And we also know that cancer tends to mutate as a patient is going through treatment. So if a patient recurs, that cancer is not the same cancer, may not have the same mutations that it did when the patient originally had the cancer. So using some of these tests to test the mutations within the cancer, again, helps us to focus in on what's the most appropriate treatment.
Sure, thanks. I'm also interested in, other members of your team. So, cancer is complex and often requires, not just the surgeon like yourself, but the medical oncologist, the chemotherapy doctor, and also the radiation oncologist. Who are the colleagues that you have here at Providence St. John's that help you? Do you rely on those people or consult with those kinds of specialists, and how do they help your practice?
Yeah, within our clinic, we have our medical oncologist as well as a radiation oncologist. And, almost every week the team meets and talks about different patients and what may be the best treatment for those patients. So they're getting a different perspective from the different types of doctors, because based on that patient's age, their quality of life, their cancer, how invasive their cancer is, they really require different treatments and a multidisciplinary team. But what's really important too is the support staff for the patient.
Right.
So we have, nurse navigators to help the patient make appointments and to make sure that they're followed up on. We have, nurses and nurse practitioners that focus on survival. Means, after your cancer is treated, it's a whole nother life for some of these patients, and making sure they get good follow-up and even social work care, and even in some cases psychiatric care or counseling care for these patients. So I think at St. John's we provide a wide variety for these patients, from not only the different types of doctor specialties they may need, like medical oncologists or radiation oncologists, but also a support staff for them.
What are some of the technologies that you use during surgery with robotics that help you with kidney surgery?
So one of the best advances that we use with the robot that you really don't have the ability to use open is something called ICG.
Yeah.
And this is a chemical that fluoresces under fluorescent light. It fluoresces green, so you're able to identify structures. So the robot camera has a fluorescence function on it, so you can give the dye to the patient in specific areas, so you can locate organs, and then you can turn on the fluorescence, see where it fluoresces green, and understand where you need to be. You can also use the fluorescence to see if something is well vascularized, or if something's healing well, or if something's bleeding. So that's really some technology that we didn't have when you were doing surgeries open.
Right. So tell me a little bit about also how newer technologies, I know that you use some 3D reconstructions for kidney surgery that help guide, how to save as much of a kidney that you can. With kidney cancer, it's important. Obviously, kidneys are vital to life and to avoid dialysis if possible. So, if someone has kidney cancer, what's a couple of technologies you use to help understand if you can spare a part of the kidney or not, how you make that decision, and how you proceed during surgery with different technologies to aid that?
So, one of the technologies we use is a 3D technology that makes a 3D image of the patient's MRI or CAT scan. And what this allows me to do is if a patient has a mass in the kidney, I can use the technology to see how deep into the kidney the mass is, how big the mass is, and how much of the kidney I could leave and or save in order just to get the mass out but preserve as much kidney function as possible. The other benefit of this technology, it really gives me a bird's eye view of where all the vessels are to the kidney. So I can avoid important vessels and keep the kidney well vascularized even during the procedures. With the robot, you can actually feed the 3D images into the screen in the robot. So I can see the 3D image while I'm doing the operation, so that can help guide me in real time. Before that, you could put the CT scan or the MRI up in the room, but you'd have to turn your attention away from what you were looking at in order to review the images. So the 3D technology, has really helped us understand how the masses are located within the kidney and how to preserve important structures in the kidney while we're doing the surgery in itself.
Yeah, I'm interested in some of the research that you're doing. I know that you have some research where you're looking at different kinds of markers, genetic markers in the urine, for instance, to help identify certain things. Tell me just a little bit about that, please.
So kidney cancer is one of the only cancers that we don't have any biomarkers for. There's blood biomarkers for prostate cancer, for colon cancer, for pancreas, for ovarian cancer, but we don't have any true way of identifying kidney cancer.
So when you use the term biomarker, what does that mean exactly? It's like a blood test, a urine test, or
a biomarker can be anything from tissue, blood, urine, fluid, even, spinal cord fluid, any type of bodily substance that actually has a marker in it that provides you with information regarding the patient's cancer.
So that could be used for screening to try to newly diagnose cancer. It could be used to follow up and see if the cancer is coming back or responding to treatment?
Correct.
Yeah. And so what's some of the research you're doing with biomarkers in kidney cancer?
So because there's no known blood biomarker or urine test that we have for kidney cancer, we've been looking at patients before and after surgery, checking their urine blood for specific DNA sequences that are both within their blood and they're in their urine and in the tumor, and then tracking those sequences before and after surgery to make sure that those sequences are gone after surgery, which they should be.
Right.
And as we're categorizing all these certain DNA sequences, we're also using them to predict if they're in the urine, what type of cancer the patient may have from in their kidney or even in some cases in their liver or in other organs.
Earlier on, we talked a little bit about your fellowship in urologic oncology, and you work with fellows here at the Cancer Institute. Tell us a little bit about what a urologic oncology fellow is, what he or she does, and how you work with them.
So a urologic oncology fellow has already completed their residency, which means at this point in time they're board eligible to be a urologist. So at this point they come to work with us to learn more about robotic surgery, specifically different robotic techniques, different ways to remove a mass from the kidney or to take out a bladder or lymph nodes or a prostate. And so it's a very specialized fellowship that really focuses on using the robot to either take out cancers, remove cancers, or even do some reconstruction as well.
So the urologic oncology fellow is someone that works with you both in the clinic and also in surgery to help manage patients. Some patients might feel like they don't want the second-hand guy participating in their care, or that the fellow isn't somehow qualified. Tell us, how does a fellow enhance patient care and make it better, if possibly?
I think having a fellow is very important. Again, remember, this is a board-certified, board-eligible urologist. They've completed their urology training.
Right.
And they can help us take care of the patients, to be more available to the patients, to help prevent emergencies with the patients. And when they're in the operating room with us, it's another urologist who knows exactly how the surgeries are going to be done that is assisting us, versus in other places it could be a PA or a nurse or someone that may not really understand a lot about urology helping you with a surgery.
Right. So I'm also interested in, what you sounds like you have an academic practice, a university level practice in urologic oncology in a community hospital. Tell me a little bit about the resources that are available to you, like, with imaging, pathology, other specialties, medical oncology, available to you as a urologic oncologist that could be better or worse than an academic setting.
So I think the benefit of having what we call a pseudo-academic practice, where you're in a community hospital, but you're still continuing to do academic research, you're still continuing to teach fellows, that's sort of the academic portion of it, is a very unique experience, because in community practices, especially a hospital like Providence St. John's, you have very renowned world-class physicians from all over the West Side that come and practice at our hospital. So you have the best in imaging, you have the best resources and other specialists that the patients may need while they're visiting you. You have infusion centers, you're collecting data for research, you're still able to offer all of these patients multiple clinical trials that you would find at other big institutions, except in our practice, it's a much more personalized feel. So you get the benefit of the small hospital, the world-renowned physicians, and the really personalized care with all the things that the academic center has, except everyone around you is a professional and not a trainee.